Thank you, chairpersons, for your kind introduction. Namaskar and good evening to all the dignitaries and the audience present over here. Premature ovarian insufficiency is no more a fancy term mentioned in the textbook. Today, it has become a pressing problem for all the gynecologists as well as the physicians. However, as an Indian, I feel proud to tell you that this term, this premature ovarian insufficiency, which has been coined maybe some 20, 30 years back in the Western medicine, has been mentioned in our Vedanta long, long back. My presentation, please. So, 1500 years before Jesus came in this earth, in Atharva Veda, it was mentioned about the premature ovarian insufficiency, definitely in some other name, but it was recognized by our physicians. We are proud about that. And 1600 BCE, Shushruta Shamhita, you know, our oldest medicine book from India, mentioned Rajaksha, which means the premature ovarian dysfunction. Talk about the Aristotle, it's 350 years back, and the International Menopause Society, which was established in 1978, found out the age of menopause, round about 50 to 52 years abroad, and Indian Menopause Society, which was established in 1996. We did some studies, some epidemiological studies in 2000s, and we came up with the data that natural menopause should happen in the Indian woman between 47 to 48 years. However, the problem rises because we find premature ovarian insufficiency is not a rare condition. In India itself, out of this 100 women, 3.7% will suffer from premature ovarian insufficiency, and early menopause, that is menopause between 40 to 44 years, will happen in 12.2%. If you think about the states of India, the highest incidence is in Andhra Pradesh, 14.6%, and lowest in Kerala, 1.1%. In West Bengal, where I hail from, it is 3.8%. Now, there are lots of causes from which we were talking about the causes idiopathic for a long, long years, but now we have come to know many of them are due to autoimmune diseases, which are very common nowadays, and the genetic causes, which I will discuss in detail. And look at the other causes, smoking, which has become so popular nowadays among the young women, and that causes, due to its lot of polycarbons, premature ovarian insufficiency. And we are blessed with lot of chemotherapies and radiotherapies and surgeries nowadays, which treats the cancer patients, but ultimately might lead to the premature ovarian insufficiency. Also, there are environmental toxins we are engulfing every day from air or food or water. That's causing premature ovarian insufficiency. And infections, of which tuberculosis is very common in India, and the cytomegalovirus infection, mumps, etc., causes the same problem. The genetic causes, which I'll discuss a bit more in details, while thinking so, we should know, does menopause occur in all mammals, all living beings? No. Among the mammals, if we look at the nearest kin of the human beings, the chimpanzees with 48 chromosomes, they don't suffer from menopause. The monkeys and others don't suffer from menopause. On the other hand, the whales, they have menopause, And you can see the whales, why they are suffering from menopause. It has been found that their brain is much more mature to understand that if their younger whales, the young female whales, they conceive and they give birth to a new generation, those are much more healthy. They have much more better chromosome and genetic profile than that by the older ones. So now, after they suffer from menopause, they become leader of the pack. And while they pass in the winter season from the Arctic region to the southern part with a much warmer sea, they become the pathfinder. So can you just take into it, because it's not just dropping, yeah? Can you just look into it? Hello? Is anybody? So discussing about the whales, we should look at the chromosome number 2, which is the second longest chromosomes in the human beings, containing 8% of the genetic material. And this contains both the genetic materials for the soma as well as for the menopause. And it is shown very clearly that these gene, any changes in these gene, changes the timing of the normal menopause. So the trial reports and studies have come up from the medical centers in Netherlands, which shows very clearly that the genes that are responsible, actually there are DNA repair and maintenance of these chromosomes are mainly responsible for the age of menopause. And in any case, if it fails, then it is associated with the accelerated aging of the soma. And with this background in the mind, we should also know that our concept now must change. There is a paradigm shift from thinking that if menopause occurs, the woman ages. Rather, it is now if she ages early, then menopause takes place. So this is one of the paradigm shifts. Another I'll discuss later on. And all the chromosomes 12, 13, and 20, they are responsible for this antral follicle count, as well as the level of the anti-Mullerian hormones. And all the most significant single nucleotide polymorphism have been found in these chromosomes, which determine the age of menopause. Now you can look at the chromosome number 12, the changes over there. And these are the studies worldwide being done on the genome-wide association studies. A lot of women have been examined, and they had been found that these are clustered in the chromosome 6, 5, 6, 19, and 20. And we are not going into details because we are not geneticists. However, to us, it's important the clinical part. And the genes also, the estrogen receptor gene 1, estrogen receptor 2 gene, CYP, to name a lot of them are there. We are not going into details, but how they are affecting is by both the ways. One way, it's going via uterus, ovary, decreased ovarian follicles, less AMH and inhibin B, and loss of the menstrual cycle. On the other hand, it's acting via the brain, hypothalamus, desynchronized gonadotrophin release, we get the hot flashes and loss of the menstrual cycles. And when we look at this, this is how the genes, ESR, that estrogen receptor gene 1, estrogen receptor 2, and others act via various pathways, acting on the FSH, acting on the 17-beta estradiol pathways to cause the early menopause. Also, if we look at these, there are two other genes which act in two other ways. One by the release of the growth hormones, which acts on the follicles, and other by preventing the apoptosis, cell death, and ultimately causing the early menopause. So with a lot of other genes being involved, we are looking as the clinicians to the consequences. And the consequences, both the soma and the menopausal changes, decreased bone mineral density, increased cardiovascular risk, urogenital atrophy and sexual dysfunction, the mood disorders and cognitive decline due to its effect on the brain, ultimately leading to the impaired quality of life. And lot of other long-term consequences also take place. where there is the increased risk of the cardiac problems, the strokes, the heart attacks, metabolic problems, the dyslipidemia, the diabetes mellitus type 2, the osteopenia, osteoporosis, sarcopenia, psychological problems, dementia, life expectancy, not to talk of infertility, which I'll discuss later on. And if we look at these long-term consequences, what we should do, we have to have a comprehensive management. Not only we diagnose, but we have to tell the patient. This is most important, the counseling part. So in the history taking, we have to know whether she has got any increased chances of cardiovascular risk or osteoporosis and fractures. We have also to look at the brain portion, and we have to tell her about the lifestyle management, the psychological health, where she should go to a psychologist, to a psychiatrist, to a counselor. We should also look at the systemic hormone therapy. If we should discuss whether it should be oral, whether it should be percutaneous. We should tell her about the bone health, the heart health, the brain health. The sexual function definitely will be jeopardized, and we should talk about that to her freely, and the genitourinary symptoms of menopause. So, with all this comprehensive management, the hormone therapy remains the mainstay. And this is the difference between treating a menopausal woman and treating a premature ovarian insufficiency woman. This is a must, and we cannot deny a woman to replace estrogen hormone if she's suffering of POI. And that should be given till the age of 50 years, the natural age of menopause, whether she is suffering from estrogen deficiency or not. And this is for primary prevention, which is not in a normal natural menopausal case. And looking at this, we should also remember that there is no evidence of increased chances of breast cancer in this woman, which we should tell to the woman. And also we should say that yearly we will check you up. So with this background, we know that the woman, whenever we replace the hormone, it will take care of her vasomotor symptoms, genitourinary symptoms, cardiovascular problems will be taken care of, quality of life increase, and if she's too young, the puberty induction will be there. And when this hormone therapy is being instituted, what are the options? Earlier, we used to give the synthetic progestogens, synthetic estrogens, which are much stronger but has got a lot of side effects. Then we started with the conjugated equine estrogens, and that also is not natural to human being. So later we found that is giving increased chances of cardiovascular problems, the strokes and breast cancers. So now we have switched on to the natural estrogens. A lot of natural estrogens, we are using valerate 17 beta estradiol, the natural estrogens, and progestogens, as the uterus is also there to protect the endometrium. And apart from giving medroxyprogesterone and non-ethesterone, which are much more androgenic, we have now switched on to the micronized progesterone, norethindrone acetate, or in some cases, the intrauterine levonorgestrel device. So as we are giving her HRT, we have to counsel her properly, because she is the woman who has to continue with the treatment. She cannot stop it in between till the age of 50 years. So talk her about the natural estrogen. It is safe. And if you give it in a micronized form, where the surface area of each small molecules, of the small particles, are much more. They'll be absorbed more, bioavailability will be more, and they'll be very low dose persisting throughout the day in her circulation. The liver metabolism will not be jeopardized, and GIT first pass effect will be there. So this is how the micronization is being done, and in order to improve the absorption, and estradiol is broken down into smaller particles, and they are being absorbed easily. So estradiol valerate giving in the micronized form along with the natural progesterone or norethindrone is now the drug of choice. However, for cost control, somebody prescribes the contraceptive pills. They are also giving very good result. However, for a long term cannot be given due to its synthetic nature, and hormone-free period cannot be given in that. Now, it's very important to think about a lot of women will have comorbidities, what to do in those cases. So, in Turner syndrome, as we discussed, it has to be given till the age of 50 years. If someone is treated for breast cancer, we cannot give estrogen. But if somebody has got breast cancer in the family, mother or anybody like that, and BRCA, she is BRCA1 or 2 positive, in that case also, it is not a contraindication. We can give, if her prophylactic bilateral salpingo-oophorectomy has already been done. In that case also, we can give her estrogen. In endometriosis, treated, operated, after salpingo-oophorectomy is done, we have to give estrogen along with progestogen so that there no reactivation of the disease. If she is suffering from migraine, estrogen being a contraindication, but in POI, we have to give estrogen, transdermal, low dose, and even if she has got aura, estrogen is not contraindicated that in case. Hypertension, obesity, we must be giving. There is no contraindication. Transdermal estradiol will be better in our case. Even in a venous thromboembolism, after discussion with the hematologist, we have to prescribe in a premature ovarian insufficiency the estrogens, which are contraindicated in other women. Cardiovascular disease, after consultation with the cardiologist, a low-dose transdermal estrogen can be given to this woman. And a woman with a fibroid also, it's not at all a contraindication. We have to give estrogen with regular follow-up. So keeping this into mind, it has got a wide range of application, and all POI patients have to get it. What about the non-hormonal and complementary therapies which some of the menopausal women take? It cannot be given in the POI patients. They do not have any benefit out of it. There is no evidence out of it, and therefore it cannot replace the HTs, the hormone therapies. Some of the women, even with the oral systemic estrogen therapy, will get some genitourinary symptoms. In those cases, we have to give local estrogen therapy, some moisturizers and lubricants, hyaluronic acid based, and a broad progesterone, that is intravaginal DHA, is given. And they are also giving oral ospemifene, which is not available in India, but they are giving good results. Regarding the sexual function, we have to discuss in detail and clearly and tell her if she has got painful intercourse, she can use a 4% aqueous lidocaine jelly, she can use a local estrogens, and transdermal testosterone therapy for the hypoactive sexual disorder is very important, but giving testosterone for a longer period of time is not advocated for 3 to 6 months because the long-term safety is unknown in these cases. The source of presentation here is from the International Menopause Society white paper, which was produced by the President Nick Paney, who came to India during my presidency in 2018. And after that, this white paper, we all of us contributed something over there, and it was established, and accordingly, we are treating them. Lastly, the fertility in POI, a few slides on that. We cannot deny a woman who has got POI coming to us asking for a child. What can we do? In autoimmune cases, in idiopathic cases, in toxin cases, sometimes if she quits smoking, she can ovulate once or in a lifetime, and she can get a rare chance of pregnancy. But ideally, the oocyte donation or embryo donation with IVF ICSI is the treatment of choice. However, stem cells are coming over here. Today's science, tomorrow's future. And now we can discuss, but I'm not going into details. Many a times in these cases, we find that the size of the uterus is small, and here we have to give estrogen. 2 milligram of estrogen valerate we give for almost 6 months of time so that the musculature develops, the endometrium becomes thick, and the vasculature, which is very important for placentation and to prevent the recurrent pregnancy failure, we have to treat them with the estrogen before doing any IVF ICSI. And also in these cases, PRP is given, the patient's platelet-rich plasma infusion in the uterine cavity. In our center, we are getting good result with it. And stem cells, the new therapy in infertility today's science, is to generate the new oocytes, and in the treatment of the Usherman syndrome is being done regularly nowadays. And we find that young woman in the premature insufficiency, there may be her own bone marrow stem cell can rejuvenate whatever eggs are left behind. And these are called the leftover eggs, the primordial oocytes. And if we give platelet-rich plasma directly injecting in the ovaries by laparoscopy or by vaginal route, that gives a very good result. And lastly, whoever the uterus is not congenial for any transfer, ectogenesis is coming up in 2016. 13 days size fetus is made in the lab. Though due to ethical issues, we cannot talk about that, but maybe that is the future of the birth. In our center, we are doing a lot of genetic studies. We have come up with the 2 genes which are causing recurrent abortions, which are causing recurrent pregnancy failures, and genetic profiling is being done. We are looking at the POI patients, and in our country, all mothers are called Ma, whether she is really a mother, she is suffering from POI, has got menopause, but everybody is mother. And if you look at our Upanishads, there it is said, there is no shed like mother, no resort like a mother, no security like a mother, no other ever giving fountain of life.
देव्यै नमः ॐ अम्बिकायै नमः ॐ परमेश्वर्यै नमः ॐ ईश्वर्यै नमः ॐ अनीश्वर्यै नमः.
And in India, long back in the Rig Veda, it was mentioned that for the benefit of the human being, whether a male or a female, a mother or someone who is not being able to become mother, someone suffering from even POI, we should find out some way or other for which science is progressing. And in Rig Veda, it was mentioned, Charai Beti, Charai Beti. So keep moving, keep moving, keep moving until we can satisfy everybody. Thank you very much for your patient hearing.
ॐ विजयायै नमः.
A very nice presentation from spirituality to science to new advances. And I was thinking how we can prevent the POI by improving the and health of the female and reducing the use of the plastic, pesticide, infanticide. How we can improve our environment. So we should think how to prevent the POI. Treatment options are so many, and early diagnosis is always helpful to prevent the late complication.
Thank you, Ratnabali Madam, for that fantastic deliberation. And I think now we've incidence of this POI is really increasing in our practice. And of course, these surgery, whenever we do an IVF, say an embryo donation or an oocyte, it's really, really rewarding. But destiny and nature you can never overcome, because I remember one of my patients who just was a doctor and conceived spontaneously. So that 5 to 10% who have a sporadic ovulation really need to be taken care of. And sometimes we have these patients coming up with primary amenorrhea if the ovarian function ceases before puberty. And of course, they are lifelong friends, because if we really look after them, we're going to save her brain, her heart and bone, and of course, her longevity also. So thank you so much.
Thank you, ma'am, for a nice lecture. And as rightly said, madam, that now this paradigm shift regarding the menstruation, menarche as well as the premature ovarian failure. The menarche is also going little earlier, and as well as the ovarian failure is going also earlier. But when it comes to a treatment of ovarian failure, premature ovarian failure, particularly in perimenopausal and premenopausal women, we always think about thromboembolism and the contraindications and the complications of giving this treatment. But when that patient's requiring the fertility treatment, the IVF specialist, this is a contradiction. Just I'm telling that when that patient goes to the IVF specialist, they are very free to give all estrogens and progesterone. So it is depending upon what the patient is needing and what the treatment is required. That's accordingly the treatment is to be given. Thank you again so much, and thank you, this Walter Bushnell people, for arranging this nice gathering. Thank you.
Yeah. Thank you, Dr. Ratnabali. That was a wonderful talk and mesmerizing talk on all aspects of premature ovarian insufficiency. What we should use rather than failure. It's more sympathetic to the woman. And we are seeing now cases. I've seen unmarried girls, 24-year, 26-year medical students, and like medical college students, and they become very much depressed. And also we have to raise, as Dr. Mahesh said, their morale that there is nothing. We can give you hormonal therapy. You can, and just like with womb donation, they can have conception also, and they can have normal lifespan. And Dr. Ratnabali beautifully highlighted that new research is coming up where we can use POP, stem cell therapy, and although they are still experimental, but definitely we have to consult them. We have to be more sympathetic to them, and we have to do lot more research on premature insufficiency, including chromosomal aspects. In AIMS, we were doing study, and lot of patients had some chromosomal anomalies we found in them. So thank you very much for that. Thank you.
Thank you. Thanking Madam Sushma and the officers of Walter Bushnell for this opportunity. I thank Dr. Ratnabali for this very educative talk. Apart from the educative talk, I found empathetic talk also. And with this, especially in March, as we are nearing Women's Day, I thought this talk was empowering women and educating them with compassion and communication. So it will go a long way if these talks are spread to other doctors also. Thank you very much for this opportunity.
So very nicely brought up points on especially genetics and understanding the chromosome 2 and 13 and all, which is very, very important for all of us to be genetically educated now, because genetics is now the buzzword. And if you don't know genetics, then previously gynecologists think genetic diseases, there's no treatment. But at least preventive and at least diagnostic and counseling is very important. And when we talk of fertility, now these POI patients may spontaneously ovulate and even get pregnant. So that has to be kept in mind. And then when we take them for IVF, instead of jumping straight to oocyte donations, we can try injecting PRP into the ovaries. And what we do for the endometrium is we do it subendometrially, not instill it in because if you instill in the cavity, it is going to come out. So hysteroscopically subendometrial and ultrasound guided into the ovary is a good idea. Of course, stem cells, autologous stem cells taken out at the same time in the OT from the iliac crest, washed and prepared, because we're not allowed to process the stem cells and use. And now in India, we're also getting commercial exosomes available. But these commercial exosomes are not by Korean company, not authorized for intra use, only for surface. So they're being used for aesthetic gynecology a lot. But there is a study which has recently been cleared by ICMR, and I'm a part of it with Dr. Prabhu Mishra, that exosome preparation machines and prepare them yourself in the OT, and then you are allowed to inject them into the ovary. So we'll be starting this study in January, or maybe a couple of months from now. The protocols are approved by ICMR, and whoever is interested, I think we would love to have some participation from all over the country. And of course, by 2070, artificial wombs will be there. So it's already there, artificial wombs. A sheep has been reared till half of this thing, and human beings will be born from machines. So you'll be able to see your baby in a glass container and feed it and talk to it. That's coming. Thank you very much for inviting and keeping this session, interesting session here. Thank you.